and thank you all for being here for our next installment of our IACH for Pharmacists webinars. I'm Katie Gatwood. I'll be moderating the session today, and I'm super excited to have with us here Dr. Sarah Maryon Hayes. She is going to be speaking with us today about integrating cardio-oncology practices into the treatment of hematologic malignancies. And Sarah is just such an expert on this topic. I have personally seen her speak on it before, and she does such a wonderful job. She has a great deal of expertise in her own practice. She's a board-certified hematology-oncology pharmacy specialist at North Memorial Health in Minnesota. And she actually has done several speaking engagements on this topic, like I mentioned, and also has created virtual rotations in cardio-oncology for pharmacists across the country. She's an active founding member of the International Cardio-Oncology Society Pharmacy Work Group and has done a lot of research and training initiatives within this specific, topic area and specialty. So I think she's going to have a wealth of information to share with us today. We're very excited to have this topic here. And before I turn it over to her, just a reminder, please pop in any questions that you all have into the Q&A box throughout the presentation, and we'll go through and address those at the end after she completes it. So thank you all, and Sarah, please take it away.
Wonderful. Thank you, Dr. Gatwood. Just going to share my slides here. Just really appreciate the opportunity to talk to you today and hopefully generate some good discussion on this topic. It's a topic, no pun intended, near and dear to my heart. I became interested in cardio-oncology years ago, actually, as a resident. We had a patient that had a very young patient that had passed away on ECMO. And it really sparked my interest in the topic and gave me a lot of drive to see what I could do to help patients never go through what he went through. So kind of came from arose from kind of a personal case for me. But the guiding principle of this is we want patients to get their cancer treatment. And you're going to hear this theme the entire time today that I speak, that there is this tug of war between cardiology and oncology as specialties. And we're not trying to take away the oncology care or therapy. We're trying to optimize the cardiovascular system so they can get their oncology care or therapy. So we want them to get the best cancer therapy with the lowest possible cardiovascular impact, is the whole point of it, is to unite the two realms. I really like this statement: disease-related and therapy-related. So two very different things that we have to marry and keep in mind together as a pair. These adverse cardiovascular effects demand close interdisciplinary collaboration between cardiologists, oncologists, and that includes nurses, that includes physicians, that includes pharmacists, that includes lab, it includes everyone in an interdisciplinary manner. And now that patients are living longer with their cancer, maintaining their cardiovascular health has become more clinically relevant. And, cardiovascular disease is the #1 killer, but in the United States, it's the #1 cause of death. But just right behind that now is cancer. So we've got the top 2 leading causes of death kind of duking it out for that top spot. But we want to optimize both so that the patient can live as long as they can and as well as they can. We have a lot of challenges in this, though, because the clinical trial patient population is often relatively healthy compared to what we see in clinical practice. And there's a lot of drugs going on. One of my favorite physicians I work with just the other day was a curmudgeon and said, "I hate myeloma. Why can't there just be one drug?" It's like, sorry, man, there's 4. And we don't necessarily know what to attribute to what when we have these multi-drug regimens going on. Plus, our trials just aren't that big sometimes. So it takes real world experience to see enough patients to really know if there's a cardiovascular toxicity associated with the agent. Another challenge is that this data is from Cleveland Clinic, from their cardio-oncology specific clinic. And only about 1 in 5 of their patients is a hematology patient, mostly lymphoma patients getting doxorubicin, I presume. But the rest of the data really lies in the solid tumor space. So we have even less to work with in the hematology realm. So I'm going to kind of blow through this and give you kind of a potpourri of some of the takeaways that I have when I think of each disease state, from myeloma to leukemia, lymphoma, and then in the transplant world, how could I forget? And then lastly, close out with some cardio-oncology initiatives and just general principles and some pearls of advice that I have to offer from us trying to get our own program up and running and making it successful and having it be beneficial to our patients. Got these these are the bubbles in my head that come up when I think of multiple myeloma. The proteasome inhibitors, the IMiDs, the alkylators, the monoclonal antibodies, they're all so different, but we use them all in combination. So we have to think about all of the cardiovascular toxicities while we're using all of them. This is from the European Society of Cardiology, the European Heart Association guidelines, which were published at the end of 2022 now. It's hard to believe it's been that long, but they're a beautiful, very large, very extensive and thorough set of guidelines that walk through all the different classes of anti-cancer therapy and kind of their recommendations for how big of a risk is it to give this patient this therapy? And then what kind of monitoring should I do? What should I do about the cardio-oncology aspect of their care? And they have these charts, which these bullseyes represent the risk of each cardiovascular toxicity along with the different agents. So the bigger the bullseye, the more at risk you are. So try to, if you need to squint your eyes, do that, but try to really focus on the biggest bullseyes, such as melphalan. We know that is the most arrhythmogenic conditioning regimen that we have. We know that lenalidomide causes clots. We know that carfilzomib is associated with hypertension, heart failure, and that with our MABs, we're looking at hypertension, but is it the other agents or is it the MABs? We don't know, but these are kind of the big things that we pay attention to. Of course, with our IMiDs, we have this major clot risk. And the problem is you already have this pro-inflammatory state with the myeloma, so then you add on the IMiD therapy and you get all these cytokines in this inflammatory state, and then you have extra risk for clots. So I pulled this straight out of the United States package insert, checked it last night to make sure there weren't any updates. And you can see here, VTEs are very common. So we prophylax, we use our SAVED score, we use the IMPEDE score to risk assess our patients. So the clotting is what we think about with this. With the proteasome inhibitors, though, we're thinking a lot more about the cardiac toxicities. So CHF, interestingly, in the bortezomib literature, it says any treatment-related cardiac disorder, 8%, and that's a warning in the package insert. I'm not pulling that from the deeper part of the package insert. I'm pulling it from the actual warnings with the agent. And whereas with carfilzomib, we have a VTE risk, arrhythmia risk. Again, is this attributable to the carfilzomib or another drug? I don't know. But when you get down to ixazomib, you've got almost no guidance, just peripheral edema as a warning. So again, there's just so much going on in myeloma. It's really hard to know what to attribute to what, but these are risks that we take with these agents. And then with our monoclonal antibodies, CD38 primarily is what I see in clinical practice. Again, we've got these combinations. They say hypertension is anywhere 20%, 30, 40%. Okay, so what do you do about it? And that's what the guidelines say here. This is really important. We don't treat a cardio-oncology patient like we treat a cardiology patient. And that's because we're looking at their cancer amongst all of the other things that we're looking at. So we're looking at their prognosis and what shape they're in. And we're not going to aggressively go after chasing a blood pressure and driving them down. Plus, if you do that, it often just gets you into trouble and leads into problems with hypotension. So you can see here the guidelines are pretty relaxed on when you actually treat 160 or above. I think we can all agree on that. Once you get into those 130s, 140s, they're like, meh, take a look at the patient in front of you. We may be causing hypertension, but it's permissive a lot of the time. So don't overtreat your patient, and plus add on more pharmacotherapy and just side effects in general with the more cardiac medications that you add. Leukemia, here are my thought bubbles. And I picked one of them because each of these could easily be their own separate presentations. The FLT3 inhibitors, of course, notably the QTC prolongation, is something that we as pharmacists manage left and right? And that's can be very difficult to interpret. EKGs, is that QTC number, is it real? Is it, what am I looking at here? So very major involvement on the part of pharmacists with FLT3 inhibitors, and especially with the new one, which is actually dosed based on the QTC interval, which is very interesting. BTK inhibitors, atrial fibrillation is, classic with the bleeding risk. The later you go in generations, the lower the risk gets. So we're seeing less of it in clinical practice, but just kind of bread and butter BTK inhibitor toxicities. But the BCR-ABL class is really, really interesting. And that's because the off-target effects of these tyrosine kinase inhibitors are so scattered and variable. And that's why you see GI toxicities with one class and not with the other, or raging QTC prolongation with one and not the other. And I had to throw this in. This is my BTK off-target picture of all the Spider-Mans kind of pointing at each other. It's just like, what is going to what here? There are so many off-target effects, but they all inhibit BCR-ABL to different extents, of course. But you can see anything from bleeding to clotting to low counts to high blood pressure. It just really depends on your agent. And this is the table in the guidelines that's used. Note they sprinkle in here some pericardial effusion, pleural effusions that can occur with the second and third generation BCR-ABL TKIs. And then the vascular toxicity is really specific to ponatinib and nilotinib. So again, it helps you kind of focus, maybe if you're counseling a patient on they're switching from one generation to another, or within a generation in the class, what you need to tell them, like, I know you've been on a drug that does this, but this is going to be really different this time, potentially, and we're going to monitor you for quite different things. Let's throw in a patient case just to exercise our cardio-oncology muscles here. CL is a 70-year-old woman on second-line therapy for CML. She's on dasatinib, 100 milligrams daily. She was on imatinib. She had really bad muscle pains, so she got switched. And she's, from a cancer perspective, doing very, very well. Her CML is under very good control. And she presented to the emergency department with this EKG strip. Notice there are no P waves. We are in AFib. And it's an AFib RVR, refractory to IV metoprolol. So we tried beta blockade, not successful. So we're going to start an IV calcium channel blocker to try to gain control of the atrial fibrillation, and apixaban for stroke prophylaxis. Her vitals are all pretty stable. She has a normal echo, which is critical for diltiazem. You cannot give diltiazem to a person with a really poorly functioning heart due to the negative inotropy. So again, we're exercising our cardio-oncology muscles here. And she's a little thrombocytopenic, which is not surprising given her disease and her treatment. So we look at the bleeding, we look at the clotting, and we pause and we say, what's her CHADS2 VAS score? It's a 3. So she does qualify, being greater than 2 and being a female, for that anticoagulation. Her has blood scores is a 2, so relatively low. Okay, so we've got our feet kind of under us here. This is where everything sort of explodes. We started with an anti-cancer therapy, and now we're dealing with 2 other moving parts that are totally different and out of left field. There's a lot of drug interactions in cardio-oncology. In fact, there's an entire paper, a statement from the American Heart Association on it, which I strongly encourage you to take a look at. It's wonderful. It has a lot of great charts, and it really just kind of helps you reason through and think through the cardiologist brain in this. And that's something that I have been astounded by in working in cardio-oncology with cardiology trained pharmacists. They think so differently than we do. It's just astounding. And they say the same thing about us. So that team collaboration is really important. But it's also important to pick up your own skills and be able to do some of their work too. So dasatinib is an inhibitor, diltiazem is an inhibitor. So basically all of the concentrations of all of our drugs are going to be higher than one without the other. So it's pretty significant drug interaction. And thinking about the pharmacokinetics versus the pharmacodynamics. What is the body doing to the drug versus what is the drug doing to the body? We've got an increased AUC of all three agents. What does that mean? Dasatinib, we're going to see increased toxicities. Diltiazem, we're going to see potentially hypotension. And with apixaban, with decreased metabolism of apixaban, you'll see an increased bleeding risk. So those are the risks that we face. And again, we're back to the tug of war. What is the risk of the AFib hurting this person? And what is the risk of her leukemia hurting her? Back and forth. And if you ask a cardiologist versus an oncologist, guaranteed most of them are going to give you pretty different answers. So it's prioritizing the most important disease state and then working together on both of them to maximize your therapy. So from an oncology perspective, I want to minimize toxicity. I want to increase efficacy. Okay, I want to keep the CML under control. I don't want to bail on a drug that's working just because we now have new atrial fibrillation, a possible side effect of the drug, and now medications that are going to interact. So I want to keep my dasatinib, is what the oncologist said in this particular case. Okay, so what can you do about that? Well, you can switch to a different TKI in the class or consider asciminib. You can consider different dose of the same medication, or, is she appropriate for discontinuation? That's a whole nother discussion. But what can I do with this therapy to make it work with my new AFib and with my new AFib management strategies? So then, okay, if you want to bury your feet in the sand and say, no, I want to treat the AFib, forget the oncology piece. I want rate control. I want rhythm control. I want antithrombotic therapy. And I don't want that chemo drug to get in my way, is what the cardiologist was saying. Okay, so we're going to very cautiously dose titrate diltiazem because it has a long half-life and it can really jump up and scare you if you go too fast trying to titrate it. And then eventually we're going to go to oral. So is it going to be a calcium channel blocker? Do we want to retry beta blocker therapy? Consider early ablation, again, in talks with the cardiology team based on the situation. And then for apixaban, Dr. Gatwood and I were just talking about how in clinical practice, we often do things that are not in the package insert, not on label. And certainly in this situation, given the thrombocytopenia, the patient's age, the consideration for a dose-reduced apixaban, even in patients that don't meet the weight criteria, the age criteria, and the serum creatinine criteria, you're like, well, let's meet halfway. Let's do a 2.5 of apixaban. Edoxaban, which is studied in cancer patients, comes up more than I'm used to from a cardiology perspective, because we just don't use much edoxaban in hematology. Warfarin is a disaster, but it's always a consideration if you're absolutely stuck with it. So in this case, we ended up dose reducing the dasatinib to 70 milligrams, and she was started on the apixaban with very, very close monitoring of her platelet count. We started out weekly, and then we got kind of comfortable with being in the 50s, 60s. And of course, we maintained very, very close monitoring for her CML therapy to ensure that the new dose of dasatinib was appropriate. So there's no right answer here, but we had to give and take in all of the different areas of her care and really work together. I was really surprised by this, that during cancer treatment, AFib is more common really even in the heme malignancies than the solids. And I don't know if I would have guessed this, because I think we just see so many more solid tumors. So that's who we generally see on these DOACs and whatnot. But it's very common in these hematologic malignancies, most prominently multiple myeloma, followed by leukemia, followed by your non-Hodgkin lymphoma. But I mean, that's a very high incidence. It's almost half of patients over 80 that you'll see with atrial fibrillation, which I guess when I think about our patient population, it makes sense. It's just that this graph really struck me. I hadn't thought about it this hard, and thought it was really interesting. For lymphoma, I can't believe I haven't mentioned anthracyclines yet, right? Everybody's like, isn't this going to be an anthracycline talk? No, it's halfway into the presentation, and we're just now bringing up anthracyclines because they're the most, thoroughly studied. We know the most about them. So wanted to sprinkle in some other fun stuff before that. Of course, Anthracyclines are a dirty drug of oncology. We've got myocytes getting ruined. We've got mitochondria getting ruined. We've got reactive oxygen species reaping havoc. And it's just the dirty drugs of oncology with really every mechanism you can think attacking at the heart, which is great to fight cancer, really bad for the myocardium. We use this 400 milligrams per meter squared cutoff a lot. More and more, we're seeing 250 as a really good place to pause and stop and think we're at a pretty decent risk of cardiotoxicity. I personally think that's actually even a little too high because our breast cancer patients are getting 240 with AC, and we see plenty of cardiomyopathy from cancer therapy in that patient population. But 250 is being thrown around a lot now. But there's this late toxicity, which is probably an indicator that there was a lot more damage going on behind the scenes for a long time that we just didn't catch, and then it finally manifested as acute heart failure. Then there's also this shock, this really quick, often reversible anthracycline induced toxicity that can happen very, very early on in therapy. And again, that's usually reversible. It's like the heart just got smacked, is how I think about it. So there's these two different types, and you have to distinguish, but they're not really distinguished in clinical trials. So you do need to keep that in mind when you're looking at the data and rates and whatnot. And what they say in the guidelines is you're doing this baseline assessment. So before you touch the patient, you're doing all this stuff. You're not waiting until they develop heart failure, and you're not waiting till they're short of breath 3 cycles in. You are doing this at baseline. And it is easy for me to say, and I will tell you from personal experience, it is very difficult to do. The oncologists have enough going on, and they moaned and groaned when we added this on to our treatment plans in the medical record, because it's more labs for the patient, more labs for them to follow up on. Insurance being a jerk because they don't want to cover global longitudinal strain assessment on the echocardiogram. They just want to cover, their standard, which is without global longitudinal strain. You wouldn't believe it's like 50-50, the insurance rejections we get from that. It's just adding more, but it is so important. And I really had to make a case to our oncologists to say, look, these are our heart failure rates, and this is why this is beneficial to our patients, to kind of give them the why behind we're doing all of this at baseline so we can take appropriate steps at baseline to mitigate the cardiovascular risk. This is from the guidelines as well. And I've mentioned this several times. I think it's actually really interesting when you start using it in clinical practice, because most of our patients are like medium at least. We have very few low risk patients. A lot of them are high or even very high. And it's not often in clinical practice, not working in pediatrics, caveat, working in the adult patient population, that you see low or medium. Most people are at a pretty decent, look at just age alone, over 65 puts them at a medium. So it's the vast majority of our patients that we're risk stratifying as medium or high, and that has created several cardiology referrals, more than several, many cardiology referrals to try to optimize their cardiovascular health at baseline before we smack their heart with an anthracycline. Referral to cardiology, we just literally have this in our treatment plan because our oncologist is like, I don't know what the cutoff, I don't know what the, arrhythmia versus, just tell me what I need to do. So I put this in our treatment plan very, very clearly to be able to say, look, this is just when we refer, and this is straight out of the guidelines. And so it makes it easy for them. It's like, we're literally right there for them to read. And this is the kind of monitoring that the guidelines recommend. So if you have a low risk patient, you're doing all that stuff at baseline, just like I said. But once you get into the medium and high, that's when you start folding in the biomarkers, the troponin, the BNP. These lab values get gnarly before the patient's heart shows structural signs of damage. So they're very, very helpful signs to be able to kind of forecast, okay, this person is potentially at risk for heart failure or maybe developing an early cardiomyopathy. And then with a high-risk patient, echo every other cycle is what's recommended. I often just see, not just, but, you know, cycle at the end of cycle 3, we'll repeat, we'll halfway through the chop or whatever. Um, it's sometimes hard for insurance to even agree to this. And for many oncologists, this does feel very aggressive. So that's why it's helpful if you're like in a big center, if you have a cardio-oncology program with a cardiologist managing this, to kind of take that burden off the oncologist. It can be a really nice treat to have that managed. And then the guidelines say here, what you do with this information. They separate it into asymptomatic and symptomatic. And keep in mind, the definition of heart failure is quite different between CTCAE versus AHA versus now ESC, which is specifically for cardio-oncology. And they have all these recommendations where, okay, you can continue if you're 50 and above is that number that we see thrown down all the time. You interrupt if you have a more significant LVEF reduction. Then when you're symptomatic, it's like, all right, look at the patient in front of you, interrupt, stop, use heart failure therapy, obviously, if they're symptomatic or severe. And then you can add in stuff for prophylaxis of further heart damage. But guidelines, again, are guidelines. And I very often run into, okay, I see what's on the sheet here, but their cancer is going to kill them. So we need to push forward. So that's when we really buckle down and say, hey, cardiology, come give us a hand here. We're proceeding with this cardiotoxic therapy in a very high risk situation. Risk versus benefit, right? You interrupted therapy, now what? Well, this is where the cardiology piece really comes in. You optimize their heart failure therapy first. And almost all of the trials, either in the management of this or in the prevention of this, you're going to see ACEs and beta blockers. We're starting to see more of the SGLT2 inhibitors, mineralocorticoids here and there, but really it's your ACEs, ARBs, and beta blockers that are the cornerstone of therapy. And you don't restart the anthracycline until their LVEF has recovered. Of course, we have these tips and tricks that we use to try to mitigate cardiac toxicity, like minimizing that anthracycline dose. I've seen some docs prefer like a continuous infusion, like an EPOC, instead of a CHOP to help mitigate the pharmacokinetic profile of the peak. I have seen liposomal doxorubicin, if you can get it covered by insurance, used in place of doxorubicin. There was a large meta-analysis on this, and it was pretty questionable, but it was a pretty messy meta-analysis given the heterogeneity of the patients in that study. And then dexrazoxane being added. I get asked this sometimes, can I use dexrazoxane with a continuous infusion like an EPOC? And well, there's no data for it. It doesn't really make sense. The whole point is you're giving the dexrazoxane and quickly thereafter giving the anthracycline. So I don't know, you don't want to minimize your cancer therapy efficacy either. So the data for dexrazoxane is mostly in pediatrics and again, very, very messy. So I see it, can't give you the data for it if my life depended on it. And then very close cardiac monitoring continues to be very important, obviously, when you restart an anthracycline. Lastly here, I just wanted to dive a little bit into the world of transplant and these bubbles that come up in my head. And this, as I alluded to at the beginning of the presentation, is really, really tricky too, because you have the cardiovascular toxicity of the transplant itself and everything that's going on with the transplant, in addition to the medications. So this can be really, really hard to pull apart. That's why everything you're going to see here is really all about that combined risk of things. What puts your patient at high risk? This is straight out of the guidelines, again, the ESC guidelines. Allogeneic transplants far more likely to see cardiovascular toxicities early, which they consider within 100 days of the transplant, and then down the road as well. And this makes sense for all kinds of reasons, right? Much higher risk procedure, and you've got all these like calcineurin inhibitors on board causing all of their own cardiovascular toxicities after the transplant. So it makes a lot of sense. Pre-existing disease, that's kind of a duh, or risk factors. This radiation therapy is a huge factor. And as a pharmacist, obviously, I don't understand it very thoroughly, but it really, really, really plays in. Even decades down the road, like if you have a patient that had a Hodgkin lymphoma and 2 decades later develops a breast cancer, it's a very, very heavy risk factor, unfortunately. There's that doxorubicin 250 I told you about, or the equivalent. And then TBI, alkylators, in particular cyclophosphamide, melphalan causing more arrhythmias than anything, and then GVH, causing that pro-T cell inflammatory environment, can be very, very hard on the endothelium, so that you can see a lot of vascular toxicities in particular with the development of GVHD. The mean heart dose is actually this like thing that they can calculate now, and they're looking literally at where the radiation was and how much volume of the heart, as they put it, was in that radiation field. And based on the part of the heart that got hit with the radiation, you actually see different toxicities. For example, if you hit the LAD, you can see more coronary artery disease. The radiation is accelerating atherosclerosis in real time. So very interesting. I kind of figured it was all just, well, heart failure. It's like, no, there's all these different things like valvular disease that can pop up even from radiation, depending on where it was localized to. For childhood cancer survivors, the guidelines break this down into two. So they say, did they get radiation and an anthracycline, or did they get both? Oftentimes they're getting both, right? So it'd be the chart kind of on the right, and that's at a doxorubicin dose of 100 milligrams per meter squared is where they go, this is a very high risk patient. And again, it's that impact of the radiation therapy that's so profound. They recommend echoes every 2 years if they're high risk. So keep that number in the back of your mind. If they're moderate risk or childhood, adolescent cancer survivors, it drops down to a 5-year interval. But yeah, every other year echocardiogram surveillance is what is currently recommended for most of these patients. This is really interesting. So a group at Michigan just published this. It's the CARE BMT risk score, and they took about 2,500 of their BMT patients, autologous and allogeneic, grouped them all together and looked at the data of what they had and then their risk for cardiovascular disease. And they broke it down into 4 different things: their demographics, their type of cancer and transplant, their comorbidities, and then a couple lab values. And they developed this really interesting score. And then they took that score and they brought it to Rush and they tested it out on another about 1,000 patients of theirs to kind of validate the score. And so now we have this score, and it's novel in that we've had scores previously, but they were mostly based off of pediatric data, whereas this is really just adult-centered data. So it is kind of a new, fresh tool that we have that's kind of fun. Again, though, most of our patients are going to be high risk, right? Because it only takes 5 points to hit high risk, and like greater than 65, allogeneic, done. You know, it's a pretty low threshold to call someone high risk. They looked at what the most important pieces are for the development of cardiotoxicity following a stem cell transplant. And they found that anthracycline use is the #1 most important factor, which I thought it surprised me. I thought maybe one of the others would have been in contention for the lead there, especially the transplant type. I know it's just below it, but age I thought would be way, but no, it's really the anthracycline history, the pre-existing coronary artery disease, that vascular disease that's there at the transplant time, and then the type of transplant. So this data really kind of helped me like reframe, well, I thought it was all like, well, they're 80 and they have chronic kidney disease, they must be high risk. It's actually, it's dependent on different things than I was expecting. So I thought this was a really great study that was published. And this brings me to my last kind of point here, that we now not only have cardiology and oncology, we have cardio-oncology, but now we have a subspecialty of cardio-oncology, which is called bidirectional cardio-oncology. And this field fascinates me. This is the interplay between cancer and cardiovascular disease that we are just now scratching the surface on. And a lot of the data is in colorectal to start, because there's something between colon cancer and cardiovascular disease that we haven't even yet begun to master. There's studies looking at if a patient presents to an oncologist first and then, starts cancer therapy, whatever, and then goes to a cardiologist for a cardiovascular issue, the mortality rates are different than if it's the reverse. The doctor that you see first can impact your chance of living or dying from the cancer based on if your cardiovascular system is tuned up, or if the disease is known prior to starting the cancer therapy. So I thought that was really, really interesting. And they're looking at it too with like, okay, if you see primary care, then you see a cardiologist, and the order of it can affect outcomes greatly. So a whole new field, very, very interesting. But we know there's a very strong link between these two giant categories of diseases, and it's just now starting to be elucidated and kind of played with. A cardio-oncology initiative, I'm not going to lie, it's not easy to start. You have to have patience. You have to be ready for a lot of challenges, a lot of interdisciplinary talk, and a lot of people working together. And most importantly, you have to be ready to educate the patient so that they know, because they're the primary ones that have to be able to tell you if they're symptomatic or something from their cancer therapy. And as we all know, sometimes patients are hesitant to speak up. They don't want their cancer therapy to be held because it's what's treating their cancers. They're afraid to speak up. So that patient education is key in the early identification of the toxicity. Early is the key. You can't let it get out of hand. You got to treat it right away, and then appropriately treating it is key as well. And that's often in conjunction with the cardiology team to optimize their cardiovascular system. Again, they just look at things so different than we do. A big academic medical center, you might have your own cardio-oncologist. There's no formal definition of what that means. However, there are cardio-oncology tracks within many of the cardiology fields and societies. We don't have any in oncology yet. There's just not that interest, but there's a huge interest in the cardiology space. And often these oncologists are very specialized. I do breast, I do lung, I do CAR T with a pharmacist that's dedicated, and all of these fancy tips and tricks and things that they can use, interventional stuff, electrophysiological stuff that in the community we don't have, right? So in the community, it's usually a general cardiologist that's like, I took a cardio-oncology rotation and fellowship and I have an interest in it. They're not like a designated cardio-oncologist, and there's no cardio-oncology clinic. And the pharmacist is also going to be kind of a generalist, right? Seeing all types of people with all types of cancer, just like the oncologist, with kind of limited research, limited tools, and really dependent upon the support that you have, the bandwidth of IT, the bandwidth of, do you have enough echo techs? Do you have enough space in your clinic? It really comes down to the nuts and bolts of just having the resources to do it. So cardio-oncology can look very different in different kind of treatment settings, whether you're in an academic medical center or out in the community like I am. Finally, this is my final slide, just a reminder that in the cardio-oncology model, the patient is that core and they have to be educated. But then you've got all these specialists and specialties surrounding the patient, and then this whole team of people surrounding them. And we're a very, very integral, needed part of that team. to serve as a resource to all of these specialists and colleagues to best optimize care for our patients. Because, as I said, it's not easy to just start a cardio-oncology program. It takes a lot of disciplines, it takes a lot of time and a lot of passion. And ultimately, it is what's best for the patients, though. And I think, I'm excited to see more and more of these programs popping up throughout the country and to see it just be folded into the standard of care in the treatment of our hematologic malignancies, where it's just kind of second nature to us, and we're using these tools, looking at our patients every day to optimize their cancer care, but also their cardiology care. So that is all I've got for you today.
Thank you so much, Sarah. That was fantastic. Let's see. Yeah, we have one question in the Q&A that I see here. So what would be your therapeutic approach for managing a 75-year-old with diffuse large B-cell lymphoma and an FEVG of less than 40%?
Yeah, I think honestly, I would need a little bit more information, and Dr. Gatwood, please feel free to weigh in. I would need to know more about the nature of that lymphoma. Is it, MYC rearranged, BCL rearranged, double hit, triple hit, expressor, double expressor, to really prognosticate that patient. And typically I see it come down to the nature of the large cell lymphoma when physicians are making this decision. Interestingly, in terms of,
And
gutsiness,
they
oh, go
are
ahead.
adding a couple more details. So
Oh,
cardiopathy, post heart infarct, and then non-double hit, it looks like. So
okay.
not as much of a high risk.
Depending on the overall fitness of the patient, I would typically see a physician choose something like an RCVP, which is like a CHOP-based regimen minus the anthracycline, especially at the age of 75. And if it doesn't have those high-risk features, probably being able to get by with an RCVP type regimen with a pretty good chance of response and cure.
Great. Thank you. Yeah, I agree. Based on my experience for sure.
Yeah.
Something else that you kind of touched on in the transplant section, which I want to see if you have any thoughts or opinions on, is the use of post-transplant cyclophosphamide that obviously has become, more and more popular, not even just in haplotransplants, but outside of, being used in a lot of other donor types as well. I know a little bit of kind of emerging data now on alternative dosing strategies for PTCy. What are your thoughts on those, and who might be the best candidates to consider for a reduced dose cyclophosphamide regimen?
Yeah, so when you look at it was in JACC Cardio-Oncology, JACC, they just did a recent kind of review on cardiotoxicities in transplant. That's really good. But if you go to the table, the cyclophosphamide data is really high dose. It's like very old data, decades old. And so we're really kind of new to this lower dosing cyclophosphamide. The cardiotoxicity, the myocarditis that can happen with cyclophosphamide alkylating, and the heart failure is all really in high dose. And it is a very dose dependent toxicity. So there are 3 trials that have looked at PT-Cy. 2 of them said there is no cardiomyopathy associated with it, and one of them found potential risk for increased risk of cardiotoxicity. So it's super mixed, and we don't have a lot of data, but as of right now, the general consensus from the authors is that it's probably safe at the dose that we're giving it. So just because it is such a reduced dose, and we did have 2 negative trials, and the 3rd trial is kind of a little bit kind of garbage in, garbage out, just based on the study characteristics from what the authors kind of gleaned. So general consensus, PT-Cy is pretty darn safe from a cardiac perspective.
Awesome. I think that's really reassuring. I think a lot of people are, concerned about that, especially as we're using it more and more. So, awesome, helpful.
Thank you.
I think that's all we have as far as Q&A. So I think we can finish things out. Again, we really appreciate you taking the time to be with us and present all of this really valuable information. So thank you so
Happy.
much, Dr. Hayes.
Thank you. I hope you
All
have a
right.
great rest of your day. Thank you.
Yep, you too. Thank you.
Bye.